This is a PU surgery on a cat with a history of repeated blockages. We have already placed his purse string suture around his anus. He's positioned on his back with his legs hiked up over his head. Caudal is to the right of the screen and cranial is to the left to keep you oriented. Here I'm using a pair of blunt tip tenotomy scissors to dissect the subcutaneous tissue ventrally. You want to keep pretty much all your dissection ventral. It's when you try to do too much dorsal dissection that you can get in trouble with nerves that affect incontinence. So here I'm just dissecting the ventral subcutaneous tissue. There are two little bleeders that you can see at the cranial aspect of the incision on the left. Nowadays, I usually just throw a mosquito hemostat on those and take it off before I close, and that pretty much takes care of the bleeding, and they don't need to be ligated. So we are dissecting ventrally to get to the pelvic inlet, and we are getting close. So looks like we found the pelvic inlet. Now we're going to cut the ischial muscles off of the pelvic floor. We want to cut down right on the pelvic floor rather than through the muscles. That cuts down on bleeding. And you want to get those muscles completely off the pelvic floor, all the way up. So we're going to do that on the right side. And then we're going to go to the left side. And then once we get that freed up, we're going to transect that ventral penile ligament. And that can be a little scary because you kind of sticking your scissors in there. You can't really see it all that well. What I do is I just stick the very tips of the scissors in there, feel the ligament, make sure I can feel it, cut it. I might not even cut it all the way through, but then I stick my finger in there and just break it down the rest of the way, because you should be able to get your entire index finger in there to free it up. Now we're removing the retractor penis muscle, and we're going to take that off up to the level of the bulbourethral glands. So now we're going to dissect dorsally just to the level of the bulbourethral glands. And the bulbourethral glands are not always super easy to see, but you can sort of see a little bit of change in the tissue. You see there's a little indentation, and then there's these two little fat pads on either side when you get up that are the bulbourethral glands. And then we're gonna we've got our catheter in. We're gonna cut over the urethra. Having the catheter in definitely makes it easier to find that urethra and give you something to cut over. So when possible, you can have a catheter in, at least if it's in part way, if that's all you can do. It still helps to get that incision started. And I usually start my incision pretty far distal, so that if it's a little bit ragged, that's the part that's coming off anyway. So start the incision distal, and then you've got your catheter in there, and then as you you're taking it out, watch, and then stick your tenotomy scissors in there, and then just cut right on up until you feel like a little change in the tissue. So when you're cutting the urethra, it's going to be soft, and then you're going to, as you get close to those bulbal urethral glands, it's going to change to more of a cartilaginous texture. And that's when you stop and don't go any farther. And then you should have a nice large opening. You should be able to get an 8 French red rubber in there most of the time. And so now we're going to suture the mucosa to the skin, and we're going to start with the very dorsal suture. And I use a 5/0 generic monocryl for my suture, because I usually do not remove the sutures. I used to use non-absorbable, and I found that when they came back for their suture removal, it just caused more irritation than I was comfortable with. I find that using the 5/0 Vetaquick, I have very good results with that, and I do not remove the sutures. So here we're doing the dorsal suture, and then we'll do another suture at 1 o'clock and 11 o'clock. And then we just make a drain board. I just usually put 3 or 4 interrupted sutures along each side, mucosa to skin. The mucosa should be like a whitish, smooth, shiny surface. Now, if you're doing a PU on a cat, that's not always the case, because sometimes they've had a lot of grit, repeated catheterizations. It can be bruised, torn, have micro tears. It can look very rough. So that can make it tricky sometimes, but usually it's a nice, smooth, whitish surface. And so you want to try to get, the mucosa to the skin. Sometimes try to take, if possible, I try to take small split thickness bites of the skin, because I don't want to invert too much of the skin and hair down into that urethral opening. And then after creating the drain board, put a strangle knot around the end of the penis and remove the distal penis, and close the remaining skin with, I usually just use a continuous with the same 5/0 Vetaquick. And then, very importantly, when you're all finished, don't forget to take out your purse string suture.